And because of what you mentioned, that's exactly why, taking numbers at face value would also be problematic across many trials. Patient population is different. I think there is also the time from, last therapy was also different between the two trials. And I hear that the comparative arm on the ASCENT was mostly similar to what we have normally seen in the keynote regimen 355, slightly different. That reflects more of the international diversity and heterogeneity really of treatment in that first line setting. And I honestly do not think that this in of itself is something that takes away from the data that we're seeing, given the fact that most practices really refer to taxanes as usually as standardized as sort of a first line setting. With that being said, I think that it is quite important to look at not just the absolute magnitude of benefit, but also the fact that we have an agent that managed to demonstrate an overall survival in the first line setting. Quite frankly, this is a very sick population, and I think overall survival, which was, I believe, dual endpoint, is something that we really should go back to and focus on. If you go to other subsets of breast cancer, overall survival played a major role in ER positive and selection of CDK4/6. In triple negative breast cancer, which are even sicker patients than you expect actually for them to do worse. This is just a testimony to, you want to call it the intratumoral concentration of the drug or the speed by which, time to response have been achieved. But I think that this is something that when I talk to my patients and I tell them, I want to treat you with this agent, and then my patient will ask me, okay, what is that going to do for me? How am I going to get better? I'm like, you're going to have delayed time for the cancerous one, and you're going to live longer. So this is something that I find that it makes conversations with my patients very easy. And that also, the other thing that I would highlight is, the fact that most of the patients who, when offered, different ADCs, a lot of these patients are either new to infusional treatments or might have had different oral medications, and it's been a long time since they've treatment. So infusion intensity and time toxicity is a real concern for patients. And this is the things that what actually matters to patients is what I focus on when I talk with them about these two trials. So I would think, and then going into the efficacy data specifically, 10.7 it's a pretty decent number for PD-L1 negative. And I think that this is, we hope to break that 1 year mark, right? And we hope we'll be able to see that eventually. However, in making these patients able to go 11 months without their disease progressing while giving them superior quality of life, I think that this is a very important point to make.
Yeah, as you mentioned, unique characteristics in some of the patients enrolled. The TB02 study did include some characteristics that potentially allowed for sicker patients. So it allowed patients that relapsed within 6 months, whereas the ASCENT-03 really limited to, you had to be at least 6 months out before you can go on this therapy. In the end, I think it was balanced, and about 20% of patients were relapsed within a year, but TB02, most of those patients relapse within the first 6 months. So it's good to know if we're seeing patients in that setting, here's where we have clean data that this could be applicable to you in the setting, and we do see the PFS benefit across all subgroups. So I think that's comforting where we really don't have that data from ASCENT-03 in terms of sacituzumab govitecan.